Hello everyone. In this video, we are going to discuss some important short answer questions of cardiovascular system. So these are some important short answer questions which we are going to see in this video. So the first short answer question is anasarca. Edema is defined as a palpable swelling on the body produced by expansion of the interstitial fluid volume. This accumulation of fluid in the interstitial space occurs as the capillary filtration exceeds the amount of fluid taken out by lymphatic drainage. When edema is massive and generalized, it is called anasarca. Edema is caused by a variety of clinical conditions. Edema usually becomes clinically apparent as the interstitial volume exceeds 2.5 to 3 liters. Edema develops as a response to an elevation in capillary hydraulic pressure, increased capillary permeability, a lower plasma oncotic pressure, or a combination of these changes. Edema also can be secondary to lymphatic obstructions, leading to retained fluid in the interstitial space. An elevation in capillary hydraulic pressure seen in clinical conditions like heart failure, kidney disease, early cirrhosis, pregnancy, drugs, venous obstructions or insufficiency states like DVT, hepatic venous congestion. Increased capillary permeability is seen in burns, trauma, sepsis, allergic reactions, malignant ascites. Lymphatic obstruction is seen in malignancy, post-lymph node dissection. Hypoalbuminemia is seen in nephrotic syndrome, liver disease, and malnutrition. The second SAQ is congestive cardiac failure. Congestive cardiac failure is defined as pathophysiologic state when heart is not able to maintain its cardiac output to meet the demands of metabolizing tissues or can do so only at the expense of elevating filling pressure. In congestive cardiac heart failure, patients have features of both right and left-sided heart failure. So the clinical features of left side failure are common respiratory signs are tachycardia, rales and crackles heard initially in the lung bases and when severe throughout the lung fields suggest the development of pulmonary edema. Cyanosis suggests severe hypoxemia. Additional signs indicating left ventricular failure including laterally displaced apex beat and a gallop rhythm may be heard as a marker of increased blood flow or increased intracardiac pressure. Heart murmurs may indicate the presence of valvular heart disease. Dyspnea on exertion and in severe cases dyspnea at rest may be seen. Increasing breathlessness on a lying flat called orthopnea also occurs. Another symptom is paroxysmal nocturnal dyspnea, a sudden nighttime attack of severe breathlessness, usually several hours after going to sleep. Easy fatigability and exercise intolerance are also common complaints related to respiratory compromise. Cardiac asthma or wheezing may occur. Symptoms as a result of poor systemic circulation are dizziness, confusion, and cool extremities at rest may be seen. So the clinical features of right-sided failure are on physical examination may reveal pitting peripheral edema, ascites and hepatomegaly, raised jugular venous pressure, swelling under the skin that is peripheral edema or anasarca. Nocturnia that is frequent nighttime urination may occur when fluid from the legs is returned to the bloodstream while lying down at night. The third SAQ is causes and treatment of cardiogenic shock. So the causes of cardiogenic shock are pump failure as in acute MI, cardiomyopathy, acute arrhythmia, valvular lesions like acute severe aortic or mitral regurgitation, critical mitral or aortic stenosis, rupture of ventricular septum or free ventricular septum, pericardial tamp node, right ventricular failure due to pulmonary embolism. Treatment of cardiogenic shock. The aim of therapy is to increase BP sufficient to maintain systemic and coronary perfusion and maintain volume status to ensure proper ventricular function and preventing volume overload. Oxygen inhalation is given to maintain partial pressure of oxygen of greater than 60 mmHg. Hematocrit is maintained greater than 30%. Fluid replacement is done to maintain adequate preload and ventricular function. Pressures are administered only after adequate fluid resuscitation. Drugs are used to increase BP and cardiac output in patients of cardiogenic shock. The dose is started to maintain blood pressure of greater than 90 mmHg or mean arterial pressure of greater than 60 mmHg. Dopamine is usually used in cardiogenic shock. Moderate doses, that is 2 to 10 mcg per kg per minute, stimulates beta adrenergic receptors and increases myocardial contractility and heart rate. Dobutamine, it produces greater inotropic effects as compared to dopamine. It also reduces afterload because of its vasodilating effects. It is given in doses of 2 to 20 mcg per kg per minute. Non-epinephrine is a potent vasoconstrictor and inotropic agent and is given in doses of 2 to 10 mcg per minute. It is reversed for patients with cardiogenic shock and refractory hypotension. Aortic counterpulsation, intra-aortic balloon pumping, a mechanical circulatory assist device, augments arterial diastolic pressure and cardiac output. It is used in patients not responding to medical treatment or in acute valvular insufficiency. It is inserted percutaneously and the balloon inflates during diastole and deflects during systole, reducing afterload and improving cardiac output. It also increases coronary blood flow during diastole. Definitive treatment for underlying causes should be given. This can be angioplasty, coronary artery bypass grafting, valvular replacement, or cardiac transplantation. The fourth SAQ is primary prevention of ischemic heart disease. Primary prevention generally means the effort to modify risk factors or prevent their development with the aim of delaying or preventing new onset of coronary heart diseases. There are several ways you can reduce your risk of developing coronary heart diseases, such as lowering your blood pressure and cholesterol levels. Eat a healthy, balanced diet. Dietary restrictions of sodium chloride up to 6 grams per day reduce blood pressure in some patients. Relief of stress. Patients are advised to avoid unnecessary tension. Be more physically active. Regular exercise. Isotonic exercises like jogging and swimming lead to reduction in arterial pressure. Control of risk factors. Restrictions of cholesterol and saturated fat in diet reduces the atherosclerotic complications in hypertensive patients. Alcohol intake should be reduced, whereas smoking should be stopped. The blood sugar level should be tightly controlled in diabetics. Weight reductions. Caloric restrictions in obese patients and weight reduction leads to decline in blood pressure. Keep your blood pressure under control. Thank you.